I'll just share my screen. Yeah. My name is Karina Stjernegaard. I'm a PhD student at the University of Southern Denmark and at the Zealand region in Denmark. I'm doing a PhD study on lived experiences amongst mental health professionals who have lived experiences of being in recovery themselves and how they use these experiences. So these are not recovery workers or peer support workers. These are nurses, psychologists, psychiatrists, everyone who works within the mental health system. And as it was just said, I am a former consumer myself, just like David. I spent quite a few years within the mental health system myself. And the way I see recovery, I define it as a social, a material, a cultural process that is defined by the individual itself. So I'll be talking about being in recovery, not recovering from. We can probably discuss that later. But what I'll be presenting here for the next approximately 20 minutes is my PhD project. I don't have any results yet. So this is mostly about the foundation that my PhD builds on. So this is what we know already, and then I'll show you some of my very, very early and quite raw data, just for you to see what the project's about and what these participants in the project are actually, how they are dealing with having experiences of being in recovery and now working within the mental health system and working within specific professions where they have specific tasks within the system. This is what it's all about. But what actually inspired me to start this this project, besides that I've been a professional working within these systems myself and having these experiences that I have, were some discussions who's been going on since the recovery movement actually started, because these lived experiences have been within our organizations like forever, it seems. And one of the first quotes I was inspired by was this one, who's by a prosumer that some mental health professionals define as, because they feel like they're both consumers and professionals within these systems that they're working in now. So this is a quote from a prosumer who says that people like us can get rejected by both user and professional camps for different reasons. By professionals because of our unreliability and instability, by fellow patients because we're somehow tainted because we've been on the wrong side of the couch. So I think this quote is quite interesting, because it seems like when you have these experiences of being a service user and then become a mental health professional, how do you define yourself and how do others define you within the context of the mental health system when you're in a system that maybe defines recovery in another way than you do, or maybe don't really believe in recovery in the same way that you do, and the service users who believe that it's maybe not possible to be a mental health professional because they've taught that it's not a possibility within the systems. So I think it's quite interesting to dig into how these lived experiences of mental health problems and of being in recovery live within these organizations that are trying to help others who are in recovery right now. So we have hired people with lived experiences within our organizations for quite a few years now in many Western countries. For the last 10 years, there has been a lot of peer support workers joining the workforce across the Western, especially the Western countries. And I was actually looking at a newer review who said that this hiring peer support workers was supposed to close the gap between the service users and the mental health professionals, to show that it's possible to feel better and get back into the system and kind of help the system become more recovery oriented, and to incorporate the service users' perspective into how the mental health system should be working. However, there's also a lot of concerns about what peer support has become within the systems, because it seems like the peer support workers who were supposed to kind of question how we do clinical practice actually ended up being in these paraclinical roles and not really doing anything within the system. They just stayed the same. But what's really interesting in this is that when peer support workers were hired, it also facilitated a safer workspace in terms of other mental health professionals starting to disclose that they also have lived experiences. So when we hired peer support workers, we actually highlighted that these experiences were already within our organizations. We were just not talking about them. And I've been working with peer support for the last 6 or 7 years within the organization that I'm in. And I've always wondered, why are we only believing that lived experiences are something we can find amongst peer workers? That kind of seemed to be the thing that was happening when we hired peer support workers within our system. So I started asking, why don't we use the experiences who are already present within our organizations? Why don't we just ask the current staff, do we have anyone here who has these experiences, and are they maybe really meaningful to be used within this clinical practice? Because we know that personal experiences of having lived experiences of being in recovery yourself, or as someone in your family or friends going through this, is a motivation for actually working within the mental health system. And there has also been a study done in Denmark that actually estimates that 1/3 of the Danish population is going to be in contact with some kind of with the mental health system during a lifetime. So we know that they're out there with these experiences. We just don't know very much about how they're being used when mental health professionals are interacting with the service users who are currently seeking support. That's what my project will hopefully help us know more about. There has actually been some mental health professionals within the last few years who started sharing their experiences and kind of coming out of the closet with these lived experiences when working within the system, who has been writing autobiographies and telling something about their experiences of telling this. And these are often people who's been within the mental health systems for a lot of years and don't feel like they have so much to lose when telling these experiences out loud. I think that tells a lot about where we are at the moment, that it's that hard to tell that you have had lived experiences. So I just brought some quotes from these autobiographies because I think that they tell a lot about this journey that we're on. So this is a psychologist saying that my patients feel understood and taken seriously when she tells about her experiences. They appreciate my openness and my demonstration that living and working with a mood disorder is possible. And there is another one here saying that I listened to words of caution about disclosure within the professional community. So she actually listened to her co-workers telling her that she should be careful when disclosing. Choosing to disclose continues to be the most courageous and powerful thing I've ever done in the field. She actually wrote an autobiography with one of her colleagues about her having what she describes as a manic episode, and her colleague helping her out and then disclosing about having these experiences and wanting to use them within her work as a psychologist. And there has also been in the northern countries a lot of press about psychiatrists and nurses telling about us to start having these conversations, that lived experiences are already present within our organization, then we need to talk about it. So let's dig into some of the studies that have already been done. When I was looking into this field, it seems that a lot of the focus has been on sharing these experiences within the workplace. So sharing these experiences with your co-workers and with management. It seemed that that has been the main focus point at the beginning when it's talking about these mental health professionals' experiences. And in this review from 2020, it concludes that it depends on the culture that you're working in, whether you'll be defined as an impaired professional, that your co-workers and management will describe you as fragile and unprofessional because you have these lived experiences, and that you're at potential risk of doing something bad to the service users when disclosing your personal lived experiences. Or you might be seen like at the other end of the spectrum as a wounded healer, that your personal experience are actually something valued, and that's something that seems to be meaningful within the context of the mental health services. So it's quite interesting that we have a lot of focus on what happens when you disclose within your workplace to your colleagues and management, but not that much about what happens when you actually tell the service users that you're there for about your lived experiences. There has been some studies, but not a lot. It seems to be something that's a little bit going on in the Netherlands, but not but isn't really a focus that much yet. There is a literature review that concluded that the mental health system is still in transformation to meaningfully incorporate the lived experience perspective from traditional professionals, but there is so little data that we actually don't know that much about how these experiences are being used, or if the experiences shared between a mental health professional and the service user are actually meaningful to the service user as part of them being in recovery right now. And there is still, and this really reflects what David was talking about, in these studies, there are they're struggling to define what lived experiences are. I think that's quite interesting. In this project from the UK, the Hidden Talents project about mental health professionals with lived experiences, they define lived experiences as something that we can all have, because we're all on this continuum of mental wellness versus mental illness. I don't quite agree when I look on my data right now, because I think the lived experiences reflects experiences of being within the mental health system. At least it does to the participants in my project. It's not just about hearing voices or anything like that. It's about hearing voices and being treated within the mental health system. That's something I believe is quite different when you become part of the system. And there has been a study done in the Netherlands on experiences by psychiatrists who have lived experiences and how they use these experiences within their daily practices. And they're struggling both with the relevance of these experiences on a personal level. Do I want to disclose? What will it mean for me to disclose? Also on a professional level, is this relevant in my daily practice as a psychiatrist? And on the clinical relevance, is this meaningful for the service user? Which they actually, some of them actually believe it is, but they don't know how to use their lived experiences with the conversations that they have with the service users. So let's continue to my project. This is all the background and the foundation that my project is building on. So what I'm really interested in is not the interactions between the mental health professionals and their co-workers. This is about the interaction between the mental health professional and the service user. And my working question is, how do clinical staff members' personal lived experiences of mental health problems and recovery influence interactions with service users? And I'm looking at this from both perspectives. I'm doing interviews and getting diary notes from both mental health professionals and service users for them to describe interactions where the mental health professional discloses some experiences of mental health problems and of being in recovery. How do they do it? Why do they do it? Does it make sense to them? All of that. This is all based on their experiences of doing it. And then I'm also doing a review where I'm only looking at the service user perspective. How does it feel to be a service user and meeting, for example, a nurse who's been a mental health service user herself? So I've brought some data today. Like I said, it's really raw. I'm doing my analysis right now. And I've only just started collecting data. I'm talking to 14 different mental health professionals at the moment. Psychiatrists, psychologists, nurses, social workers, pedagogues, different kind of mental health professionals who all define themselves as having lived experiences of mental health problems and recovery. And I don't define recovery for them. I don't define mental health problems either. They define it themselves. and we talk about it during the interview. So I just brought some very raw data for you to see what they're struggling with when they're deciding to share some of their experiences or not sharing some of their experiences, what their concerns are. So let's just dig into that. The first one is from an interview with a psychiatrist who does not share her experiences explicitly. She says that her lived experiences of having lived experiences with mental health, but also experiences of being within the mental health system, does not really fit in to being a doctor within this system. So she says, the conversations I'm having with the service users are more traditional. I'm a classic doctor looking for male functions, which makes it difficult to establish a more human relation. So she doesn't really think that it fits in with the framework of being a psychiatrist within the mental health system and the conversations that she's meant to be having with the mental health service users. So for her, her experiences becomes kind of a backdrop in how she performs being a doctor within the mental health system. So she, for example, says, I have a relaxed understanding of psychosis. It's something you can have. But I think perhaps that's precisely because I've experienced it myself. So the way she was talking about anxiety and psychosis like that, she was everyone can have it. It isn't anything special. And she treats it like that when she talks to the service users. So what she's doing in her clinical practice, in the way she was describing it to me, was actually very much based on her own experiences of being a mental health service user. So for example, she is taking much longer before she prescribes medication. She's actually very not fond of medication. She doesn't believe that it should be a big part of treatment within the mental health system. And that reflects on her own experiences of getting both a diagnosis and medication after only talking to a doctor for 1 hour when she experienced anxiety and psychosis herself. So she describes that she's taking longer to prescribe medication. She's taking longer before she will give a diagnosis of any kind. And she also says that her definition of a diagnosis differs from how her co-workers are working with this term. She says that a diagnosis to her is a working hypothesis, and that's also what she tells the service users. This isn't something that defines you. This is just a hypothesis we have. This is a way of us to figure out how we can help you, and nothing more than that. So this is just an example of some data from a psychiatrist. I also brought some raw data from a mental health nurse, a nurse who has specialized within this field, who shares some of her experiences. And it was quite interesting talking to her about how she's constantly having a dialogue with herself about what she should be sharing and what she shouldn't, and why she's sharing some things and not others. So let's just dig into that. So what to share and what to share, that's really what she's most confused about and battling actually every day when she's talking to service users. She told me that she shares experiences of anxiety, and she shares it in a way that she shares specific tools when you're experiencing anxiety. So she shares apps you can use, or that you can count dots in the ceiling, or things like that. That are very practical and very concrete tools you can use. So she shares that with the service users that she's trying to help. However, she has a lot in her background that she does not share, and those are experiences of being diagnosed with a personality disorder, of being at a ward, and of living with suicidal thoughts, which she still does. She's not sharing those experiences because, what she said, it's because of shame, but it's also because she fears stigma, not from the service users, but from her colleagues. That very much reflects in her describing why she is not sharing sometimes. And what she told me is that I actually think that she, the service user, would think that it was cool that I knew something about it. Yeah, and maybe that I had recovered and that I can handle the job. And yeah, I do not think that she would have any problem with that. The question is whether my colleagues would have a problem with it. So she's constantly reflecting on, okay, what gets out of this room I have with the service users? What would my colleagues think? What would management think? And in her clinical practice, she's constantly worrying about not sharing her experiences in a proper way. So she kept asking for guidelines. How do I do this without stepping on anyone's toes? Because she actually believes that this would be meaningful when she interacts with the service users. So this is actually what I brought for you today. So this is really just the foundation of my project and some of the very, very early stages of my research. I haven't published or concluded anything yet, but I hope that this will bring some reflections. Please share all of your thoughts, what you think about it, or if you know anything about it that I don't yet, since I just started. But thank you for listening.